Good afternoon, ladies and gentlemen. Thank you for being here. So, the story of antithrombotic therapy to prevent thromboembolic events in atrial fibrillation patients dates back to 1920s when several outbreaks of hemorrhagic disease were described in cattle. And after several years, in 1933, Carl Ling and his laboratory found out the hemorrhagic agent coumarin that was isolated from the spoiled hay, specifically from the clover. So this research was funded by the Wisconsin Alumni Research Foundation, WARF, and the combination of WARF and coumarin led to the warfarin. So one of the earliest recipients of warfarin was US President Eisenhower, who in 1955 was treated with warfarin due to a heart attack. Then, for approximately 60 years, there is nothing in terms of clinical changes of the approach. And then in 4 years, we have 4 pivotal trials for anticoagulation that are 2009, the RELY, showing that dabigatran 110 compared to warfarin is similar for thromboembolic prevention, but is better for major bleeding. Dabigatran 150 that is superior, so reduces thromboembolism, but is similar for major bleeding. In 2011, the Aristotle, apixaban 5 mg per 2 is superior for thromboembolism, major bleeding, and mortality compared to warfarin. Same year, Rocket AF, rivaroxaban versus warfarin. Rivaroxaban similar for thromboembolism and major bleeding, superior for intracranial and fatal bleeding. And then in 2013, the TIMI 48, edoxaban is similar for thromboembolism and inferior and superior for major bleeding. Another important trial is the Prague 17. This is a 2020 randomized trial, non-inferiority trial comparing left atrial appendage occlusion versus direct oral anticoagulants. What the trial shows is appendage closure is not inferior to direct oral anticoagulants for stroke prevention and bleeding. But then 2 years later, the long-term follow-up of this trial comes out, and what we see is there is still a non-inferiority between the two therapies, but there is a significant reduction in major bleedings in the population treated with appendage closure. So right now we have the landscape of antithrombotic therapies, either with drugs or with devices, is very wide. We have a big choice. And now, in the next slides, I would like to cover some the indications and a little bit of the gap in knowledge that we have and limitations of the current therapies. So first of all, very briefly, we have the new guidelines, and the most interesting, I would say, I don't know, interesting, but at least something that can be noticed is that indication oral anticoagulation is recommended in patients with AFib with a CHA2DS2-VA of 2. So CHA2DS2-VASc has been replaced with CHA2DS2-VA, and the gender component of the score has been removed. And but then there are some other conditions that I would like to talk today. So first of all is subclinical atrial fibrillation. So now we have 2 main trials. We have the Artesia trial published a few months ago. The trial randomized 4,000 patients with subclinical AFib with atrial high rate episodes that are detected by devices of at least 6 minutes. And these patients were randomized to apixaban versus aspirin. And this trial showed that there is a significant reduction in thromboembolic events in this population, although the anticoagulation arm was associated with a higher risk of major bleeding. Completely different results in the NOAA AF-NET6. Professor Sarkozy is one of the authors of the study. This study was interrupted prematurely due to an increased risk of the composite of death and major bleeding compared to a placebo arm. Similar population, 2,500 patients, at least 65 years of age, and the cutoff of 6 minutes used also for this strategy, although the incidence of the composite was similar between groups. Another important point is the concept of uncoupling hemostasis from thrombosis. So right now there is a lot of discussion on the factor 11 inhibitors. How do they work compared to factor 10 and thrombin inhibition? We know that factor 10 inhibition, so rivaroxaban, apixaban, edoxaban, and warfarin, work not only preventing thrombus formation, so preventing thromboembolic events, but also reducing the ability of the body to clot, so to prevent major bleedings, and the same for thrombin inhibition. For factor 11, this is hypothetically different. So we have a reduction in formation of pathological thrombi, but factor 11 inhibitions is somehow doesn't or limitly alter the capacity of the body to create a clot, to clot in response to bleeding. And this is completely hypothetical. This is like partially hypothetical. So then the next step is testing these drugs in clinical trials. So the first trial, Pacific AF, 2 different doses of the asundexian. This is one of the molecules that were developed for like factor 11 inhibition. Asundexian 20, asundexian 50 compared to apixaban. What we see is asundexian 20, 50% reduction in the risk of major and overall bleeding events compared to apixaban, and also asundexian 15, we have an 84% reduction in the risk of major bleedings and overall bleeding compared to apixaban. So then, starting from this trial, next trial that was just published like a couple of weeks ago, Oceanic AF. The trial was interrupted prematurely due to a 3-time higher risk of stroke and systemic embolism in the population of asundexian. So there is a lot of hope, at least a lot of hype around with these molecules, but there are still a lot of things that we don't know, that we don't understand, including probably the optimal dosing in these patients. Then let's move to appendage closure. So we said that Prague 17 was confirmed that there is a non-inferiority between occlusion and the direct oral anticoagulation, but there is a superiority in terms of mortality. So in this trial, this study that we recently published with the Mount Sinai group, the question was, what about severity of stroke? So is there any difference between this population? So we included 125 patients who had a stroke after appendage closure and 322 patients with a stroke on oral anticoagulation. And what we saw was a significantly higher severity of stroke at discharge and at 3 months in the anticoagulation group, either in the full cohort and the propensity match cohort. So it's true that patients with appendage closure have a similar rate, are non-inferior for stroke prevention, but based on these findings, it seems that the severity of stroke is lower with appendage closure. And this is very important because it has a big impact in terms of long-term results, long-term outcomes in terms of like daily activity of the post-stroke patients. Then, unfortunately, there are 2 big limitations of endocardial occlusion. First of all, the device-related thrombosis, and then incomplete appendage closure, so leaks, presence of leaks. So device thrombosis occurs because the device is exposed, is in a foreign body, is exposed to the blood pool, and then there is an activation of coagulation, there is thrombus formation on the device. And for this reason, until there is an endothelium forming on the completely covering the device, the patient is kept, unless there are certain conditions, generally on antiplatelet therapy, so aspirin and clopidogrel for a shorter term. And this is how the DRT looks. So here we have a pulmonary vein. This is a watchman. Here you can see also a leak in certain sections, and this is a thrombus. But we can also have Next. We can also have this kind of thrombi. This is like a really rare situation. The interventional cardiologist who referred this patient when I was in Austin asked for a thromboaspiration. I don't think it's like humanly possible to aspirate this thrombus, but this is what you can see is one DRT out of 1,000. So there are clearly some gaps in our knowledge on how to manage antithrombotic therapy after occlusion and how to better prevent device thrombosis. So, first of all, we know from interventional cardiology that a lot of patients have a resistance to clopidogrel, a genetic resistance to clopidogrel. That means that clopidogrel is a prodrug. So, in some cases, there is a mutation there is a loss of function polymorphism of the cytochrome 2C19, and in these patients, the activation of clopidogrel is reduced or absent. So we can have homozygosity, we can have heterozygosity, and so based on these findings, this observation in interventional cardiology, we decided to apply these also for appendage closure. So we said, why don't we test all patients undergoing appendage closure with the genetic testing to understand what's the prevalence of clopidogrel resistance and what we can do to replace in case there is no function. So we did this study that included 401 patients that underwent this genotype guided strategy. And we observed that 25.69% of patients were reduced metabolizers. So there was a reduction in activation of clopidogrel. So basically, there was a less protection from platelet activation in this population. So these patients were treated with aspirin, and instead of clopidogrel, we gave reduced dose on oral anticoagulation, compared to a population of 357 patients who received aspirin and clopidogrel without genetic testing. And what we saw is in the first 6 months, when generally aspirin and clopidogrel are prescribed, there was a significant reduction in device-related thrombosis, with no differences in stroke, TIA, or thromboembolism. Another point that I think this study is really not well known is that when we occlude the appendage and we take blood samples at different time points, what happens is everyone would think that the platelets are activated, but actually there is a slight peak of activation after 7 days, but basically there is a steady activity of platelet activation after 6 months. On the contrary, the most important thing that we see is an important activation of coagulation. So basically, what this data suggests is that we are missing the point. We are totally missing the target. I understand that appendage closure is an alternative to anticoagulation, but there are other ways and there are possible combinations. So based on these findings, we developed this study. So we treated patients with a standard approach, aspirin and clopidogrel, and the second group of 198 patients with a reduced dose on NOAC. So we kept aspirin for a very short period of time, 45 days, and then patients were kept on half dose on NOAC. And here are the results. So we had no DRTs in this population at 1 year, a very significant difference, but also we had a significant reduction in thromboembolic events and a significant reduction in major bleeding. And probably this study suggests, as well as the LAOS-3 combination of surgical occlusion and low dose and anticoagulation, suggests that maybe the solution might be in a combination. So a reduced dose of anticoagulation that somehow protects without increasing the risk of bleeding, plus occlusion. Based on these findings, we are now starting a randomized trial that will be run in the United States and in Europe, and USAID is the leading center in Europe. The other problem, leaks. So we occlude the appendage, but the appendage there is like still a patency, there is still flow inside the appendage. This is a meta-analysis recently published showing that if you use a cutoff, just no cutoff, so presence or absence of leaks, there is an 82% increase in thromboembolic events during follow-up. So there are several classifications of leaks. Leaks can be treated with long-term anticoagulation, and this is somehow a contradiction because we want to avoid long-term anticoagulation, or they can be treated interventionally, and in Austin we developed the three techniques that are currently used for leak closure, that are coils, plugs, and RF applications. And this is an example of leak in a 3D eyes. So what is the impact of leak closure? So we know that if we have a leak, there is a higher risk of thromboembolic events. What happens if we close this leak interventionally? So to answer these questions, we put together a series of 7 centers, including Mount Sinai, Mayo Clinic, and we collected 289 patients who had a closure, percutaneous closure. The mean age was 74, and has bled and CHA2DS2-VASc were 3.3 and 4.5. And then what's important to notice is, so the follow-up, the average follow-up between leak closure, appendage closure and leak closure was 12.4 months. And during this period, there was an annualized rate of thromboembolic events of 9.7. So it means that 1 patient out of 10 had a thromboembolic event. DRT is also very high, 3.1%. So if we see here the expected incidence of thromboembolism in this population based on the CHA2DS2-VASc, basically we had the same incidence of an untreated population. So basically we didn't do anything to this patient. So we closed the leaks. We had 73% of patients with a moderate leak, 26% of patients with a severe leak, so 5 millimeter or above. And then the procedure was a procedural duration 85. This is a procedure that has a certain number of complications, so it's not an easy procedure. And then what happens after occlusion of the leak? Patients were followed for 25.7 months, and there was a 72% reduction of thromboembolic events after suspending anticoagulation. So, to summarize, so significant reduction in composite endpoint, thromboembolic events, and DRTs. So this is an abstract on hybrid occlusion, like a anti-clip occlusion. This is an abstract that our ex-fellow, Dr. Muram, presented at the European Heart Rhythm Association this year. 130, this is the experience of USAID, Professor Lamer. So 130 patients, the success was 97.7%, with a failure in 1 case due to appendage size, and in 2 cases were not failures but were anatomical reasons, so proximity to phrenic nerve and bypass graft. There was 1 incomplete occlusion with a single clip that required the second leak, but importantly, 52 months of follow-up, annualized rate of thromboembolism of 0.7%, so very low rate of thromboembolic events. Briefly, before closing, I think this is probably the most attractive part of how to manage antithrombotic therapy, the concept of pill in the pocket oral anticoagulation. What if we have tools to inform the patient in real time that this is in atrial fibrillation and to guide treatment therapy, oral anticoagulation. So there are very few studies, also because it's hard to manage these patients with the current tools. This is a study that was developed in the United Kingdom. 40 patients. They were followed with two controls through the Merlin system with devices. And the very interesting part is that 75% reduction in time on oral anticoagulation. So we were able to reduce of 3/4 the exposure of this patient to oral anticoagulation. 33% of patients had no AFib. So those patients would have kept taking anticoagulation, and in 13% of cases there was a single episode during the study, so only 30 days of anticoagulations were required. So now we have several devices. This is a very interesting meta-analysis from our fellow Dr. Vetta with 3 million patients, and what we observed was a very high sensitivity and specificity of the different devices for rhythm monitoring. So in conclusion, currently available therapies for stroke prophylaxis are highly effective and have a remarkable safety profile. Appendage closure is not inferior to NOAC for stroke prophylaxis, but is superior for major bleeding prevention. Clipping is a valid alternative to endocardial occlusion and has no risk of DRTs and very low to no risk of residual leaks. Research is clearly still needed to clarify the efficacy of factor XI inhibitors. And then the last part, future anticoagulation care might be based on real-time continuous arrhythmia monitoring, just as diabetics adjust their daily insulin dosage based on blood sugar measurements. Thank you very much.